Thanks, Anu. Thanks for inviting me. I'm quite impressed at how many people turned up for this talk in person. So yeah, geriatric preventative medicine, a little bit relevant in our MOPD practices and possibly in our own families. Just to start off with, we understand in geriatrics how complicated these patients are. They're old, they have a lot of problems, and sometimes you can get extremely overwhelmed with how to approach these problems and how to triage them. So this is my approach, which is somewhat evidence-based, but truth is I actually got it from a blog, as all wonderful things in medicine are summarized. But this is a sort of triage list. So number one, you must always attempt to address the presenting complaint. And believe me, in practice, I regularly forget the presenting complaint. You get so bogged down with what's bothering you and what they should be doing and should we be ticking this box that, you know, you've forgotten all about the first thing that Granny said to you was that she's got a sore knee. And then she leaves with all these things to do in these papers and forms and booking. And she's like, but you know, the doctor never even looked at my knee. So that's what's important to the person, the presenting complaint, whether it's pain, confusion, breathlessness, etc., that's what you must address first. And if that's all you spend the first visit on doing, that's okay. Number two, we like to address geriatric syndromes. So some person came up with a list of them, making them all start with an I. In reality, you can kind of make anything into a geriatric syndrome. You can make loneliness a geriatric syndrome. But I mean, the concept is that you have a sort of something like, for example, immobility or instability, falls, incontinence, impaired cognition, which includes dementia and delirium and iatrogenesis. So you pick one of those, you have that in the middle of your circle, you identify what the triggers or what the risk factors or what the influences of those are. You try and address the ones that you can, you chip away at those that are reversible, and you hope that the final common pathway is an improvement of that symptom. Forget about linear disease models in geriatrics. There's no mosquito bites, you get malaria, treat with one pill. That just doesn't exist. Everything is this kind of syndromic view. So next, most important, which you'd be surprised to learn is actually number three, is the stuff that we obsess about in MOPD. Is your blood pressure controlled? Are you on your adequate heart failure medication? We put us, is your osteoporosis treated? Is your diabetes, your A1C at goal? What's your LDL doing? All of that sort of thing is actually only number three. And then number four is where we get to in this talk, which is your preventative stuff. So this is your well patient. You've addressed all of those things, and now you want to keep them well. However, saying that, you don't have to totally follow this order. There's flux between the levels. So if I tell you, number one, the presenting symptom is dyspnea, you diagnose them with COPD, you address that. It happens to be March, you're like, cool, let's do the flu vaccine because you're high risk. So you can kind of go between the levels, but number one being the most important, and believe me, we forget it all the time. The next thing is that old people, babies are all kind of the same unless they have, some illness, but old people, there's a massive heterogeneity of health. So you've got 3 74-year-old women. One is in hospice with cancer. One is going cruising with her boyfriend, and one has got Alzheimer's disease in frail care. And, the problem, we always get these patients and you think, why on earth have you done a cholesterol? You're totally immobile. You've got this, you're lying in frail care, you care dependent. Doctor, it was for vitality points. So HIV tests, all sorts of funny things that happen. So that's the problem. You can't apply everything. You have to individualize everything. So there's no like blanket rules for old people, which gets complicated. I tell my patients, these are things you can do. This is an old dear who's a very famous yogi in Australia. You can see how beautiful Australia is in the background there. Things that we can tell our patients to do that help old people: exercise, stopping smoking, not drinking too much, eating as well as you can, and having what we call meaningful living, a reason to get out of bed, something to do. We all saw with COVID, our best attempts to protect our old people resulted in them literally withering away from loneliness and isolation. So, these days it's better now that everybody's vaccinated, they must take their chances because, the alternative was worse. This is an amazing study. It's very long. I think it's 60 pages long. So you can just remember this slide. This was the dementia prevention study that was published in the Lancet 2020. And what they've done is they've tracked risk factors along the life course, and they've sort of teased out the modifiable ones. So the gray fat line is non-modifiable things. So that's genetic risk, events that have happened, probably a whole lot of things we don't even fully understand. However, early life education is protective, so we're doing well. In midlife, hearing loss. So if your parents are too stubborn to get hearing aids, this is one of the most heavily weighted risk factors to prevent dementia. 8% reduction of risk of dementia, so persuade them. Not hitting your head always sounds like a good idea. Treating blood pressure, not drinking too much, not being obese. So that's where the MOPD stuff comes in. So in midlife, if we can manage vascular risk, there's a big concentration on blood vessel health that helps you age more gracefully. So blood vessel risk, hypertension, cholesterol, smoking, and screening for diabetes. So later on, we get to smoking, we get to treating depression, social isolation. You can see how important that is as well to address. Exercise is there. Air pollution, believe it or not, Johannesburg's actually not that bad for this, and diabetes treatment or control. So that's the importance of what you're doing in MOPD, is you're actually helping people to age better by chipping away at what you can. Exercise we're obsessed with. So everybody benefits from exercise. However, you've got to also individualize this. If you've got your fit, well old person, their walking speed is good, they're cool, they're fine to do their own thing. If you've got your frail falling patient, don't tell them they must go for a walk. They're just going to fall over. So those are the ones that you intervene with a supervised, individualized exercise regimen. So that's a biokineticist or a neurophysio or something like that, that individualizes exercise to them and their leg length discrepancy and their sore knee and their off balance and whatever, and their Parkinson's and whatever. So they need specialist strength and balance training. And then once they've achieved improvements there, then they can go for walks on their own. So you just decide whether it's your free range running around old person, whether it's your sort of battery chicken, rail care old, etc. Stopping smoking, always a good idea. Even if you've been smoking and you're 80 years old and you're like, why should I stop now? You still get health benefits. So as long as you've got 5 years to live, it still will benefit you. Drinking, so 2 or fewer units, I say to, which is actually 1 drink mostly, unless it's like a very light beer or something, 2 or fewer units and 1 alcohol-free day a week. That's what I tell my patients. Alcohol sort of was in vogue, now it's out of vogue. So, these recommendations do change, but not excessive drinking. Nutrition, we don't like our frail patients to lose weight. We like to fatten them up. So, if I could prescribe more ice cream, I would. But ideally have a healthy weight. Believe me, I weigh every patient every time, and there's always this, standing on the scale. So, that stuff that runs deep, but just persuade them, that it's okay to not be too thin. It's actually better. And then they always talk about the Mediterranean diet, but don't suddenly change somebody's culture. The principles, the broad brushstrokes, fresh fruit and vegetables, home cooked food, whole grains, a little, not too much red meat, eating together, healthy fat. So, you could say that someone who cooks a sort of Indian diet, it's home cooked, it's fresh fruit and vegetables. So it's okay. You just adapt it to them and say you're doing okay with that. Just obviously not too much processed food. And, there's a rule, if man made it, you shouldn't eat it. If God made it, you can eat it. So that's what applies. And then this meaningful living, and that's different to every person. So there's not one study that says everybody must have a pet and that makes you live longer, because some people get joy out of pets and some people don't like pets. So this is individualized to use the person. And when I sit down with families, I say, you have to figure this out. This person, what do they want to do? And, especially these terribly lonely people, what's going to bring them out of their shell and what's going to bring them joy? And you try something and, okay, let's do jigsaw puzzles. They hate it. Don't flog them and make them do it and bully them into doing it. That's making them miserable. Just pick something else to do, find something. So you've got to individualize that to the person. Some more about exercise, just hopping on about it. It's one of the few things that actually makes your brain bigger. So they've done a study showing that MRI scans, the brain volume gets bigger if you exercise physically. That's aerobic exercise. Luckily here, you have to park very, very far away. So I'm sure you're all very fit from walking from your parking space to the hospital. So you're doing well. Obviously, cardiovascular health improves, diabetes can improve, osteoporosis can improve, sleep improves. And we often tell people to exercise in the afternoon in the natural light. And you gave a nice talk about sleeping, and that helps with melatonin and sleep, even in demented patients who have a melatonin deficiency. So a little walk outside in the sun in the afternoon. And like I say, we like to have an exercise prescription that's tailored to the person. What can you do? So this is what you can do to help your old people. And it's the basics. It's really nothing is complicated in geriatrics. Everything is simple. So blood pressure management. glucose management, cholesterol screening and management if appropriate. HIV screening is a thought. Weight and height, if we do serially, if you lose height, then you suspect osteoporosis, send for a bone density scan. Hearing screening, because it's so important for your brain to work. Depression screening, there's a 15-point scale we use. There's a 2-item scale, 2 questions. Literally, you ask 2 questions, and that's the PHQ-2. And you can diagnose dementia, depression, or suspected depression from that. And then also this important one, Reconcile medicines. If it's not serving you, try and get rid of it. Try and cut the script. There's a risk, even just having 5 medicines, even if they're just vitamins, your risk of falls is increased just by the number of medicines. So if you can cut medicines, that can improve people's health. What do we do about blood pressure? So we've got Sprint, we've got HiVet, we've got all these trials. HiVet is the one we use the most for our very older group, and there's certain goals that we aim for, which is a little bit less tight. Sprint, in reality, in South Africa is pretty difficult to achieve. You need lots of blood tests, you need lots of follow-up. So you just kind of do the best you can. Glucose goals are specific. There's guidelines. I think the CMJAH has a guideline about, that includes a section on older patients. So we're not going to have tight control if you're 80, because hypos are much more dangerous in that group. So you just want good enough control. You're not that worried about complications that might happen in 20 years' time. So, there's slightly different rules for old people. Cholesterol screening for primary prevention, probably we should just screen people up to the age of 75. Secondary prevention, different story. That's obviously indicated. But primary prevention, and in fact, the Framingham, which is what we use, only goes up to age 79. So, initiating statins in those 80 years old is controversial. My colleague, Prof. Tipping, is a big fan of statins, so he'd probably come and argue with me. And I know there's a lot of statin people that would probably have something else to say. Serial HIV screening. So we've actually got a 5% HIV risk sort of rate. What do I call it? Anyway, incidence, I don't know, whatever it is, in over 50. So it's probably a reasonable test to do. And it's a vitality point, if you're on discovery. So it's not a bad thought. In reality, I don't do it very much, I must say. Even though I wrote my master's on this, I probably should do it a bit more, practice what I preach. Checking serial height and weight is useful, because weight is obviously an indicator of just health. And serial height, as I mentioned, can tell you about osteoporosis, and it can tell you about, frailty and things like that. A quick hearing screen, you ask them. Obviously, if you find yourself yelling at them, that's fairly diagnostic, but you can just do a whisper test or, this test, and it's actually pretty good. It's as good as a sort of yes-no as audiometry. So if you just quickly screen them in MOPD, that's a way to, and then you can refer off to see if they can get hearing aids. As I mentioned, there's easy scales to screen for depression. Then also as part of this MOPD visit, we can discuss screening tests. I'm going to get to that just now. And as I said, any chance you have to deprescribe, get rid of pills, if it's not serving you, if it's causing side effects, decide really, is it necessary? Try and do that. As we mentioned before, hearing loss, very, very important for brain health is, having your brain plugged in. So being able to hear and see. Much higher risk of dementia if you're deaf. Why is that? Hard to say. Is the brain diverting neurons trying to hear and taking them away from important parts of your frontal lobe? Is it because you're more isolated and you're not getting stimulated? And is it that your brain is actually atrophying because of this, or probably all of the above? What about medicines? So when we look at medicines, we've got a sort of framework for getting rid of pills. So firstly, decide, is there duplication? So are they on 2 benzos? They're having Urbanol for breakfast and Rivotril for dinner. You're like, no, you're going to choose a benzo and we're going to get rid of at least one of them. Are they bizarrely on 2 diuretics? I have millions of patients and they've got, this is co, and then suddenly there's also Redac, and you think, sure, I wonder what your sodium is. So duplication, try and simplify. Is there a drug-drug interaction? And you've got those multi-drug interaction checkers. There's Medscape, UpToDate has one. You can literally put their whole prescription in and it tells you if there's any significant drug interaction. So if you've got this massive prescription, you don't have to look each one up in the SAMP. You can just plug it into one of these. Is there what we call a drug-disease interaction? And this is a very Geri thing. So have you got your patient with syncope on an alpha blocker for his prostatism? Have you got your patient with dementia on an anticholinergic? So certain diseases don't go well. And we use a resource called the Beers List, which is it's open access, so you can just Google it. There's, I think the latest is a 2019, and it has a table of these drug-disease interactions that are useful in geriatric patients. Is it inappropriate in the elderly? So there's certain medicines that we never like to give older people, anticholinergics, sedatives, those type of things that, and there's a list of those as well in the Beers List. And are we underprescribing? Should this person be on a statin? Should they be on warfarin for atrial fib? Because actually they have the highest risk and someone hasn't given it to them because they're old. So full risk is a little bit of a dubious reason not to give anticoagulation, because it turns out stroke prevention is a higher risk than, bleeding from falls. So are we not giving them what they should have just because they're old? Then we get to the advanced investigations. What should we be doing for this person? Do they need screening tests? Do they need invasive tests like colonoscopy? Should they go for a bone density mammogram, AAA screening? Should they have an eye test? Should we CT scan their chest? So this is the sort of next step in things. What are your options? So for colon cancer, you can send them for a colonoscopy, and in theory, you should have one between, I think it's between the age of 50 and 80. And if that one's normal, then that's the screening test. That's the benefit. In the UK, you can check fecal occult blood. So the NHS sends you this envelope and you provide a specimen and then you post it back to them, and some hapless person has to open all those envelopes. Lord help them. In older people, you could just do a SIGI, which is a much lesser prep than the whole bowel prep for a colonoscopy. And in theory, more cancers occur on that side. And as I said, one between the age of 50 and 80. Over 80 is a bit dicey for these colonoscopies. The risks are very high. So you wouldn't do it as a screening test. You may do it if it's symptom directed. Bone density in South Africa, they recommend for all women over age 65 and all men over age 70 to have one. But you're going to risk stratify. I mean, you can't sort of, you're going to decide who's, obviously you're going to prioritize the fallers and the frail patients and those with risk factors for osteoporosis. Do you need more bone densities? This every 2-year story, and it just depends on the results. If your result is plumb normal and you've got the strongest bones known to man, then, you can have one in 5 years or 10 years even, unless your risk factors change. You suddenly start taking prednisone or take up smoking or something like that, which will change your risk factors. Mammograms only if you're going to live 10 years. And if you're over the age of 75, they're probably not going to make you live longer or better. So that becomes a personal choice. AAA, they recommend in men who were smokers between an age to an age, and obviously you're going to sort of decide who's a big vascular path, etc. Eye testing is a good idea. It's pretty cheap. It's pretty easy to do. And then there's this low dose CT chest, but remember to pick your smokers for this test who, number one, will be fit enough if they do find something, and number two, are willing to go further, so you don't want to suddenly sit with nodules and things and not know what to do next. So don't do tests on people that you're not prepared to deal with the results in. This is an amazing website. So it's our Geri-Pal colleagues. They've come up with this prognosis website. So you can, firstly, you work out your patient's prognosis, and they've got all these buttons. Is the patient at home? Are they in hospital? Are they in hospice? And you click on all these buttons and you enter some values, and it tells you what their life expectancy is. Then you can plug this into this thing, which is your time to benefit. So you can see to make colon cancer screening worthwhile, you have to be kind of 10 years left of life. Even mammograms after you've had breast cancer yourself, you still need to have at least a sort of 10-year life expectancy for it to be worthwhile in terms of mortality risk. And, this is, is it worth starting finasteride? So that's sort of Avodart and those type of tablets, because they take an awfully long time to work to shrink your prostate. Bisphosphonates, you need a sort of at least kind of 2 years before the best before date in order to initiate therapy. Intensive glycemic control, as I touched on, you really need a long life expectancy for that to be worthwhile. Blood pressure, a bit less. Statins are there. It's hospice admission is switched around. So if your life expectancy is less than 6 months, you're good to go. If it's longer than that, no hospice for you. And then, SSRIs kick in quite quickly. I must say I haven't used Ritalin for depression, but I think they do in palliative care. So you can discuss this with your patient. It's a conversation. So don't say to your patient, because they don't like hearing this, even though it's what we're thinking, you're probably not going to live long enough to benefit from this test. Nobody wants to hear that. Don't say it like that. Say a mammogram is unlikely to help you live longer, as shown in 999 out of 1,000 women who are more than 75 years old. Don't say the best way to prevent old age is to die young. True, but don't say that. Just say we don't know the future. We can't predict everything, but we can use information from other people, so there's a script to these things. There's a script to how you put it. Don't say you're a terrible patient and you're neglecting your health if you don't do all these tests, because actually there isn't that much evidence to show that they help. So, and do explain, especially with breast and prostate cancer and low-dose CT scans, that there's a high risk of a false alarm. And those false alarms are not nothing. They're quite scary. Next thing you're having biopsies and repeat scans and you're on spilkers for the whole weekend and you're panicking and, so it's not nothing to have a false alarm. So similar to prostate cancer. So prostate cancer is really confusing. First, everyone's obsessed with their PSA and everyone wants you to check their PSA and trying to explain, you're the doctor hero because you picked up my cancer, even though it was low stage. It was never, ever going to give you any harm. You've had some sort of hectic treatment that's left you incontinent, impotent, but you saved my life because you did my PSA. So, there's a lot of conflicting guidelines. Then we've got also, if you ever get stuck in the Hollard traffic jam where they're all wearing their undies and running around this area because of this race, and then they've got this advertising people saying, 572 abnormalities detected, potentially helping to save 572 lives, actually giving up to 60% of them a false alarm and a terrible weekend. And, probably wouldn't have harmed them anyway. So it's difficult. This is what the medical aids will pay for. And believe me, they read all the guidelines. So if you're very lazy and you don't feel like reading the evidence, just see what the medical aids will pay for. So we know that Black African men are higher risk. So certainly those age 40 onwards, anyone who's got a family history and a family history of breast cancer, because there's obviously, genetic links. Otherwise, age 45 and people with symptoms, that's what they'll pay for. What about old people? As I said, don't screen people you're not prepared to deal with the abnormal resulting. You must be at least 10 years life expectancy, and obviously symptoms, that's no longer a screening test, that's a sort of diagnostic test. But look at this. This is in the NEJM from now, March. Thank you to Joe for finding it. Basically, although the incidence is highest in men in their 70s and 80s, these are exactly the men we don't recommend screening. So look at this table of guidelines. It's a little bit small, but here we have US preventative task forces, over 70, don't screen. Here we have American, where are we now? Here we go. American Academy of Family Physicians, over 70, don't screen. Even in some other countries, they don't recommend screening at all in old people. And this is because there's not a good correlation between PSA screening and mortality. And there's a massive rate of false alarms, and they're quite onerous because you go for a biopsy, there's a 5% risk of infection. Then maybe you pick up something and you have this treatment and it may have side effects. So they've got this new treatment option, which is the sort of watchful waiting to try and deal with these low stage patients. So if you screen 1,000 men between the age of 55 and 69, you only prevent death in 1.3 men after 13 years. So it's really not much bang for your buck. But trying to get this message across to the patients is difficult. So there's certain things you can look at. They're called decision aids. We don't have any in South Africa, or not that I know of. I wish someone would write them. And they're basically a very simple presentation of, this data in whatever language. And in America, they use them. And you give it to the person and you say, look, it's your decision. You can choose. This is the conversation. These are the facts. Decide what you want to do. So we need someone intrepid to come up with some decision aids. So this is also off that same UCSF website. So they've got, you can plug in data from your patient. So this is actually my own mother. She's turning 80. She still works. She's fit. She's running around. She's had breast cancer. However, look at this as her result. So it's not clear that getting screened will help this person. The thoughts and feelings are the major driver. So it's a conversation. It's a conversation, and you have to be armed a little bit with the facts. This is Choosing Wisely is an amazing campaign and this is it's various societies have their own rules. So there's a couple from the Geriatric Society, and this is important. Don't recommend these screening without considering the life expectancy, the risks of testing overdiagnosis and overtreatment of these conditions. Getting to bone densities, as I mentioned before, there's this sort of every 2 years must go for bone density in private, debatable. If you've got mild osteopenia, you could actually give it a few years before you check again, unless your risk factors change. So you've got to know the risk factors for osteoporosis. Moderate, maybe you should screen more often, and advanced, obviously, you're gonna screen them. This is for osteopenia. Obviously, if they've got osteoporosis, you're gonna treat them. And sometimes you can have osteoporosis with osteopenia on your bone density, and then you're going to do a clinical risk score, which is a FRAX, which is another talk. And once you've got the clinical risk score plus osteopenia, you may have enough evidence to even treat those patients. What about preventative medicine? So there were some on the list that have since been crossed off. So aspirin, no more. Statins, we're still fans of. Vaccines, I'm a big fan of. Vitamin D, gone out of fashion. Multivitamins, nah. Better to eat food. So aspirin, we used to have this debate. Okay, maybe does it help you not get cancer? Does it have this? Does it have that? Bottom line, not recommended in those over 70. There's actually a higher risk of harm than benefit. This is primary prevention. Secondary prevention, you've got stents, you've got strokes. It's not debatable. You must take aspirin. This is primary prevention as a preventer. However, I've got a whole bunch of patients in my practice that are convinced that their long life is due to their a baby aspirin that their GP 500 years ago told them to take, and you must never come off this medicine. So those ones I persuade to take it twice a week. How about Monday and Thursday? You don't need it so often. So you kind of have to work on it. What about statins? So we know this table. This is from our own guidelines. So obviously you're going to plug the patients in here, just bearing in mind that Framingham only goes up to age 79. Should you be initiating statins for primary prevention in over 80s? I'm going to say no. I might get argued with. This is an interesting approach that I found in the USA, which might be controversial as well. But also, do a Framingham more than 10% treat, 5 to 10 discuss, less than 5 don't treat unless they've got a really stonking LDL. Don't initiate if they're over 85 or their life expectancy less than 5 years. What about stopping it towards the end of life? Why not? You know, if you're really frail and you've got not much left to live, it's maybe just causing drug interactions and side effects. What about just giving a moderate dose and not chasing LDL and just fire and forget, you know, and hoping for the best? You can do 1 LDL just to check that they're taking the thing. And if they're very intolerant, then don't treat them unless their LDL is very high, they're extremely high risk, in which case you've got to cycle through different statins till you find the one that agrees with them. So to vaccines, these are the adult vaccines that are pretty much available. There are some others, but these are the common ones. So flu vaccines, I hope everybody's had theirs. COVID vaccines, we all know about. I'm not going to talk about those. Pneumococcal vaccines is a new guideline that I'll mention. There's shingles vaccines, and then Tdap mainly we recommend in grannies who've got newborn grandchildren, so to protect the babies. So go and get your pertussis. If you need a tetanus for any other reason, maybe get Tdap instead of just tetanus. And if you're traveling, if you're an intrepid person and you're going off to the Bundu, you can get this as well. And other travel vaccines, you might get hepatitis, you might get meningococcal, etc., especially for the Hajj. There's some rules about that. What about flu vaccines? We're obsessed with these. Flu vaccines are amazing. Flu vaccines do things you never knew they did. They have a fairly good efficacy. They have improvements. They can reduce pneumonia of any cause in old age homes and death of any cause in old age homes. If you only have a few vaccines and you have an old age home, vaccinate the staff because they'll have a better response than the frail patients. It reduces death, just having a flu vaccine, whether that's because you're a better patient and you go to the GP and you follow up and you have better health, or whether it's the effects of the flu vaccine, it's hard to tell. And it's got a cumulative effect. So if you have your flu vaccine every year for 50 years, you're doing well. So as I said, it can reduce mortality, all-cause pneumonia. Even the pneumonia vaccine is complications of diabetes, heart attacks are reduced by flu vaccines. So if you, other cardiovascular, functional decline, going to hospital, and death and frailty, all reduced by just getting flu vaccine. So do it. This is the new pneumococcal vaccine guideline led by Prof. Feldman. And essentially what the new recommendation is that if you're older than 65, you should have PCV13, which is Prevnar, the conjugate vaccine, followed a year later, unless you have a strong reason to have it sooner, by PPV23, which is Pneumovax 23. So what I usually do is this year I give you flu and Prevnar, next year I give you flu and Pneumovax a year later. There's other recommendations for people under the age of 65. There's a list of comorbidities where you should strongly consider it: renal failure, cardiac failure, COPD, other respiratory diseases. And then obviously there's very strong indications in people with cochlear implants and CSF leaks and splenectomies, et cetera, where there's a much narrower interval. But these were the 2 lines written by the geriatrician. PCV13 alone is not good enough because it hasn't got adequate serotype coverage in adults. So in South African adults, the serotypes don't match well to PCV13. So if you're going to just give one vaccine because you're worried about compliance or worried about cost, because PCV13 is costlier, just give Pneumovax 23, more bang for your buck. And also, as I said to you before, it's okay to let some of these things go because you're busy addressing other comorbidities and more urgent things in your geriatric, you know, your 4-scale triage system. So it's okay not to get here. It's okay. What about shingles? So we've got one vaccine available, Zostavax, and that's a live attenuated vaccine. So it's a bit of a problem because you can't use it in people who need it the most, which is your immune compromised rheumatology patients, transplant patients, immunosuppression. There is a threshold. I think low levels of methotrexate, you still can, but you know, the response may not be as good. So it's a tricky one. And it also hasn't got very good efficacy in older people. So look at this, over 80, it's got 18% efficacy. So we don't actually give it to 80-year-olds because it's expensive and there's not much point, which is unfortunate because those are also the highest risk of shingles. It's sort of modestly effective in 70 to 79-year-olds, but bang for your buck is the younger patients. So 50 to 60, they could get Zostavax. There is a new shingles vaccine called Shingrix, which is a sort of recombinant vaccine. So it's not a live vaccine. And this is excellent in older people. It's excellent in immune compromised people. It's got 91% effectiveness in older people, but we can only get it through Section 21 here, and it costs for 2 doses about 11,000 Rand. So tricky one. If your parents go overseas, they tell them to score themselves a Shingrix. What about vitamins? So there are some indications for vitamins. We all know about pregnancy and folic acid. All bariatric surgery, they all need vitamins. Patients who may have pernicious anemia, obviously, if they've got inflammatory bowel disease, they mentioned sideral, they might need iron, that sort of thing. If they've got osteoporosis and they're not eating enough calcium and they need vitamin D, you'd like to supplement. And then macular degeneration, there's all vitamin things. There's patients on PPIs and metformin may be deficient in vitamin B12, and PPI is also calcium. It's a risk factor for osteoporosis. And obviously patients that are malnourished, you know, you can give them vitamins, but everybody else is supposed to just eat food. And this is one of our patients. So you can see there's a very sad little, that's Neurobion, which is the vitamin B supplement. That's Plenish K, that's Ecotrin, and that's amiodarone. And can you imagine poor amiodarone swamped in the sea of spirulina, Slomag? I don't even know what half of these things are. These look like probiotics of some sort. So this person, literally, that is one day. Can you see their pill box? That is one day's worth of pills. So you're wondering why they're in atrial fibrillation, because, you know, poor cortisone. Not a hope in hell. If you get here, medico-legal stuff that we could add to your MOPD visit, maybe on the 5th or the 6th visit, driving, unless it's important because they've come in because they've had a car crash or something, driving safety, advanced directives. What about power of attorney? It's a funny law in our country. It actually falls away if you become incapacitated, not enduring like in other countries. And have you nominated a healthcare proxy? Who's your person that's going to make your decisions? So, you know, these are useful things to have documented in your file. And there's quite a lot of tools and things that you can do this quickly. So this is a nice driving safety screen. Can you figure out how to draw through a maze? And it's nice because if the person sitting next to you who's brought you can see that you can't figure out a maze, it's an obvious leap that you cannot drive. Advanced directives, if you want to do your own one, there's this website that'll talk you through it. You can click a box and then it prints it out at the end. Yeah, power of attorney, as I said, it's a bit of a funny law. It's a bit of a strange thing. In healthcare proxies, you can just say, you know, in my family, I trust X, Y, this person and not this one to make my decisions if I can't. Don't do pap smears on old people if they've had them before. And we don't recommend weight loss in old diabetics. The screening we've mentioned extensively. Don't cognitively screen them if they're asymptomatic. If there's no complaint of a cognitive issue, but you know, you can delve into that. Don't urine dipstick these patients unless there's a symptom. Do not. They all live with a bit of a bug in their bladder. It leads to excessive unnecessary antibiotics. In the older chums, in the old days, and I think some of them still do it, they used to line them up weekly for their urine dipstick, and oh Lord, they've all got hectic resistant bugs in those old age homes. And this carotid Dopplers also, they've gone out of fashion if they're asymptomatic. These are some tools that you can use. That's the US Preventative Task Force app. So you plug in the details of the patient and it gives you graded recommendations, what you should be offering them in terms of screening and what you shouldn't be. That's the UCSF prognosis site. Decision aids, I'm hoping one of you will take this up as a master's or something to come up with some decision aids for breast, colon, and prostate cancer screening that's, relevant to our patients. And then, as I said before, you can design your own advanced directive. So this is my own granny who was before her time, because her mantra, she used to do yoga. That was the yoga theme of the talk. Her mantra was actually all these things that now we've found to be true with studies. So you have to do all of these things for every day. Do something for yourself. Do something for someone else. Do something you love doing. Do something you really don't want to do. Colonoscopy. Do mental exercise. Do physical exercise. And then count your blessings. And that was her rule. Thank you.
Thank you.